Thanks for joining us for the next instalment in our series In Conversation With. This time I'm speaking with two consultant oncoplastic breast surgeons, Ms. Siobhan Laws and Ms. Rosie Stanton, and also their colleague, Dr. Nadia Urakat, who is a consultant breast radiologist. All three of them are at the Hampshire NHS Foundation Trust here in the UK. During our conversation, we touched on all of the challenges of treating patients in this current environment, but also how their adoption of MagSeed and MagTrace is helping to minimize patient visits, to help make the OR day much more efficient, and also is helping them to tackle the backlog that's built up over the last 3 or 4 months as the screening program has been shut down. Well, thank you for joining us, Siobhan, Nadia, Rosie. It's really great to see you guys. As hospitals start to open up and treat more patients and have more operating lists going, they face a number of challenges of treating their patients efficiently and safely. And I was really keen to speak to you guys because I think a number of changes that you've made over the last few months have put you in a great place to tackle that challenge. Before we get into that, I wonder, Rosie, if you could just take us through a standard breast cancer treatment pathway in your hospital.
There can be many appointments and attendances at hospital for a breast cancer patient. They'll typically come for the results of that biopsy. Then prior to surgery, historically, they'd have come separately for us to localize a cancer if we couldn't feel it in the breast, so often to put a wire down to it. They would have seen breast care nurses. They would have had a pre-op anesthetic appointment. They may have had an additional imaging appointment or an additional biopsy, and it can easily get to 10, 11, 12 appointments before an operation. And that's draining at the best of times for patients and their families financially and emotionally. So in terms of COVID, the things we're really trying to avoid, again, are extra appointments at hospital generally, because we're trying to reduce the chance of somebody catching COVID-19. And we're particularly keen to do that for somebody who we know is going to have surgery, because we know the combination of an anaesthetic and a COVID positive patient is poor, and they can do very badly after that. And then, of course, also there's an additional group of our patients who have had chemotherapy who are very susceptible, who we're particularly trying to make their pathway as safe as possible.
Thank you, Rosie. And Nadia, did you want to add something?
Yes, so screening has stopped since COVID started, so we don't do that. And at the symptomatic clinics, so now if someone comes and we are fairly certain it's a cancer, we put a marker clip in most patients, just to save them coming back for a marker, or sometimes we put a MagSeed straight away. Probably happened once or twice. We don't do it quite often, but this is again to save time, to save extra trips to the hospital for the patients.
I think you make a really interesting point there, Nadia. Certainly placing at the time of biopsy has a lot of cost implications for the hospital and is only really valid in a small number of patients. Rosie, I wonder if you could maybe talk about how having both MagSeed and MagTrace and the flexibility of when you can inject that is helping you at the moment in this situation.
What we are now doing is I will normally see my patients and give them their cancer result on a Friday morning. And when they've seen me, they will leave my clinic and go straight over to Nadia, and Nadia will then put a MagSeed into the breast if necessary, and at the same time will put MagTrace in the breast. So what that means is the patient will not need to attend again for localization of either the breast or the axilla before their surgery. So I think that has been a big step forward, both for reducing visits generally, but also for cutting back on the attendance in COVID times.
Right, let's bring you in, Siobhan. How are things different from your point of view?
Things are very different, and some of the things that we've put in place because we've had to put them in place, and some of them I think we will keep going forward. So, for example, the reason that you're seeing the home background behind me is because I'm shielding, and that means I can't come in and operate and assist my colleagues. And So how am I meant to be helping deliver the clinical care on the front line? And actually what we've done is I've adapted by using telephone consultations, and I've just started to use Attend Anywhere video consultations. And embracing some of this technology has been really positive. I think from the operating point of view, we were experienced at using the MagTrace because we were involved in the SMART study. And as Rosie's explained, we try and do everything at once if we can. So when we've made a diagnosis, they've been assessed face to face, they will then have their mark or their seed inserted, they'll have their MagTrace injected, and we try and tee up their anaesthetic pre-assessment. And we try and get everything organised during that time. And I think that's something that is a bonus, again, going forward. And if we can organise that in the long term, I think that will be really useful. Initially, we pushed for the MagTrace and wanted to be an early adopter because at the Winchester site, we have no nuclear medicine on site. So the patients had to go to another hospital to have an injection. And that's something we really did want to avoid if we could possibly avoid it during the pandemic. So again, MagTrace has been really helpful in developing that. I think the other thing I might comment on actually is that one of the things that we've all struggled with is not being able to provide the same service that we normally provide. And in particular, in the early days of the pandemic, we were restricted in not being able to offer reconstructions and the bigger reconstructions. And we felt that offering women implant-only reconstructions wasn't ideal. That was something that the ABS said would be acceptable, but we felt that they actually had a very high rate of complications and short-term complications, especially wound problems, and we didn't want them to keep coming back to the hospital and coming back to GP practices for dressings. So we didn't go wholeheartedly down that pathway either. And that's been a real struggle for surgeons who are all very committed to the oncoplastic ethos. And we all recognise that we've got quite a lot of delayed reconstruction to do in the not too distant future.
I know, having spoken to other units, trying to work safe operating around all the challenges of COVID, I think were we not to have MagSeed and MagTrace to use, we would be compromising a little bit more on the sort of surgery we're doing and the way we're used to localising things. I know many units have decided that it's too complicated to be operating on a different site and sending people for nuclear medicine and are doing blue dye only, which we know from trials is less sensitive. So I think we've had to compromise less on what we're giving patients because we have these techniques to use. And that is good, because I think for us and the patients, providing a service less good than the one we know we can deliver is very difficult.
Yeah, that must be tough, but I suppose great for your patients to know that they have a wider range of treatment options when they come to you. You're pretty well known in the UK for using MagSeed and MagTrace. Have any of your other colleagues from other institutions asked you about it and how you're using it right now?
So some of my colleagues in Nottingham have. I mean, I know they are operating off-site, but the patients are having to go first to the breast unit and be localised with a wire, and then they go in a taxi across back to the private hospital, which is actually about half an hour away. I think they were thinking about, MagSeed and MagTrace being a solution for that. Possibly. I mean, I think when you have it, life becomes so much easier. The whole headache of having to have people in 3 different places at the same time disappears, and you can actually just focus on the patient and doing their operation, and the whole localizing of the axilla and the breast has happened possibly weeks before. And I think it is quite anxiety-filled day for patients having surgery and not having to attend several appointments all over different hospitals is a real release for them.
I think you're so right. Anytime we can reduce the number of visits for a patient, it's got to be a positive thing. I just want to touch on a phrase you used earlier called a cold site. You mentioned that you're now operating in a cold site. Could you expand on that? please.
So we never know who we're talking to with COVID. A lot of patients, a lot of people who have COVID are completely asymptomatic. And so we have to really, really be as safe as we can, bringing patients with cancer in to have an operation. And so the solution for that has been that we have moved our operating theatres and the delivery of our chemotherapy from the main NHS hospital into the private sector. So we're very grateful to BMI in Winchester for loaning us Sarum Road Hospital, and we're operating upstairs and we're giving oncology downstairs.
The other thing just to mention is that we, on the advice of the ABS and NHS England, have had to look very carefully at the adjuvant therapies that we've been giving. And obviously being able to look at the sentinel node preoperatively and assess the sentinel node intraoperatively, make sure we've got the right sentinel node is very important when it comes to calculating the likely benefits of adjuvant treatment postoperatively. And that really is changing our protocols quite quickly. So, for example, changing the protocols from 15 days of radiotherapy to 5 days of radiotherapy, omitting radiotherapy in some of the older patients, and also thinking very carefully about who we offer chemotherapy to. And again, that's a game changer for us and our colleagues across the UK. But sometimes it can be, I found that I have a far more frank consultation with patients. And there's a lot more openness about that. Not that it wasn't open before, but you have to be more open because you've got these other problems surrounding it. So you have this very open conversation about implications from that decision to go forward with chemotherapy. And it's really important for us that we get that sentinel node information.
And Siobhan, what would you say to any woman at the moment who maybe recently has found a lump in her breast, experiencing some changes that she's concerned about, but at the same time is very worried about coming into the hospital to maybe have a mammogram, have a checkup, go and see their GP to talk about it, for fear of contracting anything in the process?
I could start with the sort of the pre-hospital part of it. So when we get a referral from somebody's general practitioner because they've got a concern, we would automatically give them an appointment. But what we've been doing during this pandemic is looking carefully at that referral. And if we can answer the question without the patient having to come up to the hospital, we will do so. So, for example, we know that we can often give advice and guidance rather than having somebody have to attend the hospital. We can offer telephone consultations in the first instance to see whether they really do need to come to the hospital. And if somebody hasn't got a symptom that would require imaging, for example, if all they are experiencing is some pain, then we don't need to see them in the hospital. So we can protect them from that unnecessary visit. When they do come, we try and do everything in that single sitting, and I'll leave it to the others to comment on that.
I've been here in our outpatients this morning with my 2-metre ruler measuring between chairs. We're going to have to empty out our waiting room, which currently takes 16 people and will end up taking 4. The hospital as a whole is working really hard to work out how to keep patients coming through and social distancing. We have PPE. This visor was made by one of our local schools, and they've been kind enough to make 700 visors so that we will give all our chemotherapy patients a visor for when they're coming up to the hospital. We have been treating breast cancer here for many, many, many years, and we are determined to keep doing that as safely as possible. So please come. Most of the patients that come to a diagnostic clinic do not have cancer, and that is an enormous psychological relief to find that out. So please come.
I want to say about when they come to radiology for a mammogram or for an ultrasound that the mammographers who's going to do mammograms, they are wearing PPE, they're wearing gloves, they're wearing masks, and they wear visors if needed, and we can give patients, because when they have the mammogram done, they're very close proximity to the patient, so we can give them masks as well if they want, if they feel safer, and everything is cleaned after each patient and sterilized as much as possible. Then they come to ultrasound. When they come to ultrasound, again, the radiologist and a nurse or whoever is helping in the clinic, they're wearing PPE, and we are adhering to all the guidance.
And Siobhan, how have your patients responded to these changes?
No, I'm flabbergasted by how well people have adapted to this, and how understanding they are, and how accommodating they are when they, you're changing their lives, and yet they're saying, "Oh, I hope you all keep safe," and all this sort of stuff. And it's absolutely humbling. It is really amazing to have those sort of conversations with people. But I think they do understand that we're doing absolutely everything we can to keep them safe, and whatever it takes. And it's been fantastic to be able to knock down some of these barriers. I mean, the thought that we didn't have to put a business case in to do extra mag traces and mag seeds is brilliant. It's things like that that's broken down those barriers. It has to be done. Let's do it. Let's get on with it. And it really does make a difference. And I can't say that it's saved operating time, because of course we spend twice as long with the anaesthetic, because they have to take longer to put patients to sleep and then clean the theatres afterwards. So life is different, but to reduce some of these barriers to innovation has been game changing.
Well, clearly those cancers aren't going away. Do you anticipate the NHS is going to experience quite a big surge of impalpable cancers as we start to open back up?
Oh yeah, definitely. Yeah, because the service is stopped for 3 months now, and how many cancers we haven't detected in these 3 months. And yeah, definitely we're going to be busy when we're back. And the symptomatic is going to pick up as well. So we're going to be very busy on both sides.
Yeah, I guess that's the next challenge. It's not just about being open for business, but now starting to ramp up the number of patients you can treat to try and tackle that backlog. And I guess you have to start making the most of theatre time that you have, trying to be as efficient as possible, avoiding as many delays. How do you see that, Siobhan?
We saw that before the COVID epidemic. Not having nuclear medicine on site and moving to MagTrace made a huge difference to scheduling. And although it might not have quite the same impact now, it's still making an impact. But I think having had the experience with using these materials before the pandemic meant we were much more confident at incorporating these as solutions into our routine that we use now.
The Basingstoke end hadn't used MagTrace so much, and I've been using it pretty much uniquely in the last month. And I must say, it's not difficult to take to. Injecting it earlier means you get a really strong signal and nice brown nodes in the axilla. And it probably took me 4 or 5 cases to get comfortable with it. And now I'm running with it pretty much in the same way as I would with hot and blue. And actually, I have done a few cases now of having a mag trace over a mag seed. And in those cases, we've put an X on the skin above the mag seed. And that has transformed the whole thing, because the combination of having an X and something that you might be able to feel when you're close to it, and the mag trace all together, means you'll get it. So I think that as a combination is going to work in the end with a bit of experience. And once you've scheduled patients using MagSeed and MagTrace, and you've done all that weeks before your surgery, you never want to go back. I never want to go back to having people going to other hospitals, going along corridors, having localizations in the middle of my operating list. It is just so much nicer forgetting all that.
One of the really beneficial things about having to work differently during a pandemic is the cooperation that's gone on. And I have to say, we've had the most amazing support from our radiology colleagues, pathology colleagues, all the admin staff in the background. But we identified our lack of experience with using MagTrace and MagSeed together as an issue, and we came up with a collaborative solution that everyone could use. And we do put this ultrasound X marks the spot. Now, that we may not need that in the long term, but that's really been very helpful, and it's been fantastic that we've had that support, and we've come to a collective protocol for how we do these things. And again, that's happened a lot more quickly than it would otherwise have happened, and it's very what's the right word, it's very much a collective approach, and I think we're much more together as a unit as a result of that.
Well, that's great. That's really great to hear that across the whole MDT, you guys are seeing this as a solution to how to improve the treatment that you offer for your patients. I think that's wonderful. It kind of brings me on to my next question, was going to be, how have your teams coped throughout this, and has it brought you closer together?
We're all one organism, it turns out. And if one arm moves, the other arm moves. So we've had, the whole surgical floor has been cleared for our COVID-19 patients. And it's like dominoes. You push one thing out and then everything falls in front of it. So there's been huge cooperation from management down and through all the clinicians to firstly clear the hospital so that we could bring all the COVID-19 patients in, and secondly put everything back so that we can start to get our services up and running. And the private sector have been amazing in taking us in and hugely welcoming. And have an enormous pool of skilled nurses, radiographers, managers that we've been making the most of. But it's been hard going from having a fully functional breast unit in one place to having to have a fully functional breast unit pretty much the next day in another place. And it was probably fairly exhausting. And it's nice to feel we've got 5 minutes to take a breather, perhaps before the next changes take place, which are clearly coming. I think putting our service back together again in the NHS with social distancing, with changing protocols, with second waves, third waves, whatever happens with this is going to be an ongoing process.
Well, thank you, all three of you, for taking the time to speak with me. It's been great to hear about everything you're doing there, and thanks for all your hard work. It's wonderful just to see how the NHS has pulled together and just gone out of its way to continue to offer a great standard of care. Hopefully we'll see you again soon. Thank you.
Okay.
Thank you.
Thank you.